Healthcare is a business.
Yeah.
Yeah. It's a business like any other business. So they will go they will go to the slums and open a room and write clinic on the door, and they start doing those things. Yeah, by constitution, everyone has a right. So once you open a facility, you cannot deny people, especially emergency care. Even where you cannot treat the person, at least you must do the basic. Healthcare requires a lot of patience. For the time I've been there, you need a lot of patience. For you to see very good results, you actually need to give time to everything that you undertake. Yeah.
Welcome to Daktari Tone, where voices, perspectives, and sounds relating to healthcare practitioners and matters health are amplified. This is a podcast by Daktari Online, created for healthcare professionals across Kenya. Each episode brings you honest conversations, expert insights, and real-life stories from the front lines of care. Welcome back to the Daktari Tone podcast. With me, I still have Dr. Kariuki David, the CEO and Registrar of the KMPDC. In the previous sessions, we've talked about the KMPDC mandate. We also talked about what practitioners need to know on licensing. And for this segment, we're going to talk about facility licensing, inspection, and compliance. And Daktari, my first question to you is, if you could, walk us through licensing, simply what a new owner or a new facility owner should know from day one.
So a very critical, important question. I think owning a health facility, of course, starts with the idea. And before licensing, there is registration. So before registration, a number of things that one needs to know. One, they need to identify the location that they want to put up their health facility. Number two, it depends on whether it's their own premise that they are building or they are going to lease it from a certain place. Then, depending on either, whichever facility and location, they will then need approvals from the local county government in terms of environmental management, issues around waste. Where will their waste be going? Is it and it's medical waste and non-medical waste. Then they will need to get certification from the county government of where they are located in terms of what we call public health occupation. So the county department for public health will give them what we call a public health inspection report that looks at how the building is done, ventilation, water, sewerage, security, all those things. Once they have that, then now they will identify who they want to employ. So once they have all those, they will now then apply to the medical council. They will fill in, the documentation that is needed. Currently, it's an online process, so they will do it from the comfort of their offices or home, and upload. Because in the recent past, one of the changes that has happened is we now have what we call the Data Protection Act. And the healthcare data that we collect is considered sensitive data. Therefore, they need to also register themselves with the data commissioner and get a data protection certificate registration. So once they have all these documents, they will upload them, bring them to us. We verify the information. One of the critical things, they have to choose who will be in charge of their services. So who is the person with the highest medical skill among them? Is it a nurse? Is it a clinic officer? Is it a doctor? Because that also determines the level of facility that we are going to categorize. Yeah. Is it even a specialist? All that.
That leads me to a good question. I'm asking even for myself and other people who are not yet in the medical space. Can we start a facility?
Yeah, you can. Because at that point, healthcare is a business. Yeah. It's a business like any other business. Only that it's a business that requires compassion and such. So you may have non-medical people investing in healthcare business. So the most critical thing for the day-to-day running of the hospital is the person they will present to us as the medical director or the clinical services director. Because when that hospital will have challenges with the service delivery, that is the person that KMPDC will ask. And we have many examples in the country. Many hospitals. For example, maybe as an example, the Aga Khan, is a hospital. Maybe the owner is not a medical doctor. Is probably a person they say is giving back to society and such. When you look at maybe let's say Mater Hospital and many faith-based facilities owned by the Kenya Catholic Conference of Bishops or Kenya Conference of Catholic Bishops, they are not doctors generally. So they have enough money to invest in healthcare. But each of them usually gives us either a medical superintendent, chief executive, even where they have chief executives, they have to give us the director for clinical services. So when a patient complains against the hospital, we direct our questions to the clinical director.
And a good question now. Let's say personally I want to start a facility. I do not have any medical background, but then you've laid it so well. Do I have you've already said I have to have someone who's answerable and has a knowledge around medical or a clinician or someone who is answerable. But then do I have a limit of staff members who are well versed with the
you see, now in your staffing, it will depend on whether you are starting a small clinic, a health center, or a hospital. So that will determine the number of staff.
So let's start with a small one. I'm starting with a small facility.
A small facility may even just require 2 staff, maybe even 2 nurses. That will just be a dispensary. You may require you may require, if it's a health center, you may require to add a doctor, a clinic officer. Now, a medical center may now even have a laboratory and a pharmacy, so it means you will require those staff. If you add radiology, then you might need a radiographer and such. Until you get to a hospital, now you will need more doctors, more nurses.
Great. And now, why do facilities get flagged, and how can owners prepare proactively?
What we have done is that KMPDC works through rules and regulations. So from the Act, remember our Constitution says it's our right to receive healthcare services. So that's the first thing every owner should know, that by Constitution, everyone has a right. So once you open a facility, you cannot deny people, especially emergency care. Even where you cannot treat the person, at least you must do the basic and tell them where to go next, or even take them, deliver them safely to the next provider who can do it. So, that's usually
I'm going
what
to use
happens.
a hotel. So if I go to a hotel and I'm hungry, I cannot deny you. So for the hospital's case,
yes.
Oh my God, I did not. That's something.
At least if I'm bleeding and you can do nothing else about it, do the first aid. Basically, you are being told, do the first aid and then move the patient to the next. So you can get into Nairobi Hospital with a dire emergency, they can do the basics in their outpatient and then transfer you to Kenyatta National Hospital because you don't have the funds to pay. Yes, and remember now with the Social Health Authority, when fully functional and it has already started, they can pay for the first 24 hours, irrespective of the facility you get admitted to.
Is really wrong, because tell me why. I've always thought, because I think, okay, maybe also the film industry has given us this ideation where you can go to the hospital, you do not even have funds, and they tell you no person is going to deal with you until you like even pay something. So that means it's
yes, where you say you have no funds, at least they are supposed to do the most basic to make sure that at least you don't lose your life. And most of them will actually give you free transport to the nearest public facility, because public facilities by their nature do not ask for fees before one gets admitted. Yeah.
Okay. Any other reasons why facilities get flagged?
Number 2 is probably providing the wrong treatment. Sometimes we are now seeing more complaints around payment, either overcharging or such. Is another area. Yeah.
Actually, there's now another thing that has come up. I know it is something that is going on. The fact that I might be in the public hospital and then I have started my own hospital and now I decide to refer someone to my hospital. That is something that has come up actually more recently. If I didn't see it yesterday on news, I don't know, just somewhere around this week. What's your thought on that?
Let's say that is more about an employer-employee relationship, because whenever an employer, let's say Kenyatta National Hospital or a county government hospital or any private hospital for that matter, when they engage a doctor practitioner, they should clearly set terms. What times do I expect you to be in my facility, and what times are you free? So once that is set, then it is possible to now determine whether that time this person is found in a different place is the same time they were expected in their primary. So one chooses their primary place of work and then goes by the contract of that primary place of work. So if it says I provide, let's say, 48 hours in a week has 24 times 7 hours, is 168. So that person has another 100 hours to do whatever else they wish. Resting is one of them. And maybe they can now do that other, they can do medical work, they can decide to go farming, they can get into media and all those. Yeah. So the most critical thing is that they are working within what is agreed, and they have a contract. So if one is out of their contract, then that now becomes an issue. Yeah. Otherwise, in terms of ethics, and remember we talked about ethics, one should not steal time from one employer or patients, because that's one thing also. Even in our code of conduct, one should not take a patient, because we do what we call referrals. When a practitioner refers a patient to another practitioner for a specific purpose, once that practitioner completes that aspect of the treatment, they should refer the patient back to their primary doctor.
And now when we talk about facilities, is this only just hospitals, small facilities?
It could be clinics, hospitals.
Or do you also deal with pharmacy?
Well, the pharmacies are now dealt with differently by the pharmacy board. Those are now chemists, they dispense medicines, yeah.
Now, if today was to open a clinic, what are the 3 non-negotiables?
One, you must be registered, because once you are not registered, then that's the facility. It must also be registered as a health institution. That is by law. Chapter 253 of the laws of Kenya says for one to provide services in a health institution, that institution must be registered. And whether it is government or even Kenyatta National Hospital is registered as a health institution.
Faith-based.
Whether, yes, now those are types by ownership. It can be government. Government can be national or county. They can be non-government. Non-government, which are private. There's private for profit, private not for profit.
But either way, all of them should be registered.
Every must be registered. And likewise, once registered, must have a license. Those two are non-negotiable. If you don't, now that's where quackery comes in. Because you are a quack if you are not registered. Yes. So even as a facility.
So there's also quack facility.
Yes. We call them illegal facilities. It is the practitioners who are quacks here, if they are not registered and licensed. So those two are very critical. Number 3 is now to comply with the standards for the level of service that you provide, offering.
Oof, okay, great. I've also learned maybe in future I'll be having a clinic and I'll remember this time.
Just employ the right people.
Okay, now on cleanliness or documentation, which one fails more?
It's documentation fails more. Documentation fails more for facilities and practitioners.
Why? I can keep on asking that question. Why?
And that's why you see we are currently moving more into what we call quality of care, because quality is largely determined by what we do and the records we keep. Because the records we keep, if we were to review, then we are able to know what we did last year, what we have done this year, and what is remaining to be done. Yes. Because cleanliness, sometimes people can keep clean and clients themselves run away from places that are not clean. But they are not able to tell whether you are documented.
But honestly, I'd commend that nowadays the hospitals, both private and public, they're almost at the standard.
Because they know if we arrive and it's dirty, one, it tells us this is not a busy place, so we need to be more keen. Number 2, it's a dangerous place because people can come and even get more infections from this place.
Because honestly, let me just give you your flowers. I've walked into facilities that if I was to walk back then in 5 years, you would feel it's a hospital. But right now, you even ask yourself, am I in a hospital, until you visit the ward or get into where now the business of medicine happens, because definitely
it's actually part of wider health sector reforms that have been there from around 2008 coming this way, where even how the hospital looks like became a factor in whether we continue allowing it to provide services or not.
Okay. What is that one inspection win story you remember?
I don't know whether it's in terms of closing or commending.
Give us both. And that one that was trying to really justify, and you were like, who do you think I is?
Of course, people see us, and as we said, they will start seeing like we have already gone to close, and we don't close. But many are like where we have saved patients from getting we can even say
Give us one. I'd like one quack story.
Well, you have heard of somebody called Mugo Wairimo, who was always claiming to be a doctor, and we managed to get him out of the system. And there are a number of others that we have also done so, but that's, I think, the most visible or known.
That reminds me, just within this year, there have been very many controversial things happening in the hospital area. One was on the transplant of kidneys, where it exposed even doctors from, and then there's also another one that came. I don't know if it was a factual story, but then we had doctors who are from, India. And then later we come now to, and I even come to now understand there's different types of licensure, where there's one where East African based doctors. If maybe you could give us like types of, like there's a Kenyan based, and then what doctors are licensed. Now East African, what does it mean? And then now from abroad, because you also have an understanding that sometimes patients will need more expertise from outside the country. How does that work? Let's say I'm a doctor from USA or from India, and I'm coming to Kenya. How does that work?
Yeah, right. Very important for people to know. So we have various types of registration. For you to practice in Kenya and in any country in the world for that matter, you need to satisfy the local requirements. So in Kenya, there are various ways. You can get registered in Kenya because you are a Kenyan and have gone to school and learned medicine. So what we do is, and you can be a Kenyan who has learned their medicine in Kenya. And you can be a Kenyan who has learned their medicine out of Kenya. Yeah. And you can have learned that medicine out of Kenya, but within East Africa or the rest of the world. So in Kenya, then it says it's direct, you get registered. So if you are a Kenyan who has come from the EAC, the East African Community presidents, about 15 or so years ago, signed something they call, an East African Common Market Protocol. So those who have trained in East Africa then become eligible for what we call reciprocal recognition. But for that to be done, the university you are training from must have been inspected by a joint inspection team and was confirmed that it is training, quality, the product, the doctor from there is acceptable to all countries in the EAC. If not, then you will sit an exam when you go back to your home country. Then we have the doctors who train from outside, but they are Kenyan. When they come back home, they will sit an examination before we allow them to be registered in the country. Then we live in one world which is called one village. Therefore, we cannot deny those who have trained to be doctors in their home countries, some coming to settle in Kenya or just to look for job opportunities to come. So we also have a way of examining them to be able to become registered in Kenya. So those are the different kinds of registrations. Yeah.
Okay. Yeah. I'm not forgetting one interesting story. Yeah, during inspection for either facility or practitioner based. Yeah, if you can share as an interesting story.
Yeah. So there was a case where we had a situation where a hospital had refused or declined to release a patient because of finances and such. And so we went there, and though they initially were refusing, but with our power as a regulator, we were able to transfer the patient from that facility to a public facility. Of course, we also made arrangements for the hospital to have, for the patient's relatives to make an arrangement on payment, because we realized that services had been provided, and yes, the hospital had used its resources, so they still need to be paid. But so when we were there, they managed to sign an agreement on how this family will pay the hospital over time and resolve it. Yeah.
And that reminds me, I don't know if it was in part also of KMPDC, just again recent back, there were some hospitals that were closed with regard again with financing. I think there was also share issues where they ended up now having closure. A big number of institutions, actually facilities, both faith-based.
All over.
Yes. Yeah. So KMPDC also take part in that?
There is no hospital you can close in the country. It's only KMPDC that can close. The Social Health Authority can cancel your contract. But for the hospital to be closed, KMPDC must be part of the team. Yeah. And we have done it several times. We actually picked it from social media, patient complaining about how they were treated in a facility. And we went there and actually closed the facility. So what the person had said on social media was actually true. So yeah.
And also that leads also to another question. The fact that also healthcare is still not there. Because again, we still have areas where there's less health facilities. You can find people walking kilometers and kilometers, and now we also have where we have to close these facilities. Are there at any point where these facilities can be opened again, or are they given a chance to check back on what they should do right, or what are the processes of? Okay, I think the first good question, and you've touched on it, but briefly, what leads to closure? And then after it's closed, what can lead to it now reopen?
So whenever we inspect a facility, we can give various recommendations. The best is that we think you are doing okay, continue. From there, we can give recommendations on specific areas of the facility which we do not think, because there are two major things. Either there is what we call a major nonconformity or just minor. So if minor nonconformities, like we expect for infection prevention, you should have 3 different color-coded bins for separating, segregating different types of waste. If you don't have that, we can allow you. Because you are providing good services, but you are not taking care of your wastes very well. And we can give you 30 days to be able to sort that. So we will not close. And apart from just writing by the way, compliance inspection is generally audit. We have checklists for it. Then we can come and find that your laboratory is so bad, as an example, that even though the rest of the hospital, the rest of the facility is good, we are closing the laboratory. So we can close part of our hospital. And it can either be even an outpatient, either pharmacy, or because we can come to the pharmacy, and though you have medicines, but everyone employed there has no knowledge of pharmacy. So why should it be? So we close it for that. Why we are closing is so that you employ
the right people. Good.
We do not stop them from being assisted, but the person leading must have knowledge. So we can close a section of a hospital. Then now the worst is where we think the whole hospital has a problem, and we close the whole hospital. So now when we do partial closure, we give timelines. In 30 days, 60 days, 90 days, we will come back either by our own volition or you call us, because we can give you 90 days and it's something you think in 40 days you have managed to resolve our recommendations. We could have come and found you have not been keeping records of the people you have seen and what you did, and we say no, we can't allow you.
And now, have we had cases where we have no permanent closure? Yes, they don't revive at all.
Very rare, because even where we close completely, we do not deregister. Because it was already a registered facility.
Take note of that.
So what we do when we close, basically what we say is we have withdrawn your operating license. So the license we had given you to continue operating is what we have withdrawn. But you as an institution has not been deregistered. Yes, so for deregistration, it needs to be very, something so gross that we have even involved the criminal investigation department and such, and then we say this facility cannot be allowed to continue existing in this country. And now we have it deregistered. We even put in the Kenya Gazette for that.
Now, that was facility-based. Now, practitioner. I have a feeling there's types of quacks. Because you also mentioned, I might have studied, I've gone through my schooling, but then the only mistake I didn't get registered in the license, right? So that makes me a quack.
Generally, a quack is somebody who has not gone into any type of training in the medical field. Yes. That other one would be a person either impersonating or something like that. A quack is somebody who has not gotten into a medical training institution. And we have seen it largely among people who work in the hospital as
cleaners,
support staff.
yes.
They are the ones
So
now
they borrowed the knowledge and then they feel like, mimi naweza fungua hospitali ama naweza enda ni treat.
And some of the things we do are by looking very simple. But and if you see me doing it every day, watch what I do. Maybe you are the cleaner around where I am, and everyone who comes with a headache and such, you know, to inject, you just tell them expose and so they will go they will go to the slums and open a room and write clinic on the door, and they start doing those things. So but the knowledge behind why you are injecting and where you are injecting and how you are doing it, they don't have. And that's why complications are.
And what brings to the rise of this, quack?
It's because we do not have now the formal services closer to where the people are.
Now that I
and you can see, like
yeah.
even in Nairobi County as an example, in the last 2, 3, 4 years, they added close to over 20 health facilities, new ones. And I think and more were in the harder to reach areas of the county, where we could say they have tried to increase service delivery. And in those places, I'm sure if the services are being given, the number of illegal clinics, like we are mentioning, has reduced. Yes.
Okay. Now, looking ahead 5 years, what is your vision for the Kenya's healthcare system?
That we will have people with more access to health services that will be of such quality that addresses their health needs, and more so without suffering financial hardship.
Honestly, with this conversation I'm having with you today, the whole ideation I had about KMPDC, just allow me to say you're doing a good job.
Thank you.
Of course, you'll have enemies who feel like you're doing the wrong thing, but when I see it from a patient base, and I'm a patient too, I see you're doing a good job. Yeah, because honestly, I've seen, the reasons why some things happen facility-based and also practitioner-based. And of course, there are those that are dangerous. And of course, health is just the center of everything. If I'm not healthy, I am not well. And if I'm going to a place where I have to get, good service and it's not in its, best environment that it should be, then it shouldn't give me those services. So it is a good job you as the council are doing.
Only good people get enemies. If you are bad,
exactly. Yes, I've had that saying. If you do not have enemies, then definitely there's something you're not doing right. Yeah.
So we try and endeavor to do the best, because as we said, we are the protectors of both patients and the doctors that serve them. Yeah.
And what advice would you give to the young doctors, dentists, or healthcare entrepreneurs?
Healthcare requires a lot of patience. For the time I've been there, you need a lot of patience. For you to see very good results, you actually need to give time to everything that you undertake. When I was very young, the best doctors when I even was getting into medicine from school, I didn't know then that it was the senior doctors I could see who were doing quite well. I hadn't seen those newly graduated doctors who were struggling by then to provide services. So I think patience is key, because even sometimes to see the outcome of the work you have done requires time. On the first day after treatment, the patient will still have pain and such, but in 1 week or 2 they will come and you won't believe it's the same you had seen, not even able to walk a few days earlier.
Okay, we've done great. And so we've reached the last segment of this session, which is quick fire questions. But before I ask my quick fire questions, I'm going to allow you to ask me a question. Yes.
What do you do on your day-to-day life when you are not interviewing
Well, I'm not
people like
interviewing
me.
Dr. Kariuki.
Yeah.
Well, I'm an introvert, big time, and most times I get to shock people when I say that. But then I love my own space. Of course, I get to interact with a lot of people during my daily, interacting with you, interacting with him, and other people. So I tend to want to go and just rejuvenate. So most times, if I'm not at work or interviewing people like you, I'll just be all by myself, either watching a movie or sleeping. Sleeping is my bestie, or cooking my favorite meals, or reading a book. Yeah.
Okay.
Yeah.
Have you ever had any interview where, it made you like cry from the stories you were being told? Or?
I wouldn't say that I cried, but it was heartfelt. Yes. Okay, so there's some interviews that I do that are off camera. They're just maybe for a story I'm going to do off camera. And most of those are the ones that are really, heart to heart, because most I'll deal even with a patient who are telling me of their ordeal, or maybe how they got to get a certain diagnosis, how they've lived with that for very many years. And of course, there's some that I even had to take a minute, because I had to be grateful for life. I was like, hey, and especially for those ones that are even younger than me. That there's times where you feel you're young, but then you meet someone who is younger than you and you feel the way their dreams have been shattered just because of a diagnosis. And of course, that will get me to my emotional state, because my tears are just here. Hey, but at the end of the day, it still just makes me grateful. So I'll ask another question, you ask me a question. I feel like you've now, you're now at par, right? That one myth that, you would wish to die. Yeah.
The myth that KMPDC exists to protect doctors.
Yes, it's a myth, but then at the same time, because I've been on the other side, I've seen the way doctors really also backlash people. So yes, it might be a myth to the people who are not there. Yes. But then when you get into the circle, you feel like, there's some things going on. You're like, but at the same time, you create balance. Just as I said.
KMPDC to the doctor is like a parent. The parent will always want to keep you, well grounded. Yeah, that's what we do.
Okay. Now, what is that one habit every practitioner should adopt? You already said patience, so give me something else.
Communication with their clients, with everyone, let's say generally. Yes, clear, effective.
And I'm still going to comment now you personally, not just as a leader. Your communication is also so, you're so calming. It brings in the leadership, and also you listen, you think before you respond. I've noticed that. You give yourself a minute, you're like, wait, what? And then you respond, and that really tells a lot about your communication skills. A question for me.
Yeah. Do I have one now, really?
Okay, let me ask you one as you think of two. That one book or principle that shaped you. Especially, you didn't say, I can't forget, you didn't say you read.
Yeah, I do.
And then no, wait. You also said motivational book. I will not forget. So please.
Yeah. When I read, there's Dr. Ben Carson, Think Big. I think it really
shaped you.
Yep.
You've thought of a question for me?
Not yet. Another one.
Okay. One policy change you are excited about.
I think the policy change I'm excited about is the movement towards universal health coverage, the decision by government to take that route is something very good for Kenyans. It may be difficult now, but over time, if we keep at it, is something very good. Why I say so is that I've been involved in UHC for long. Yeah. Even now, I'm still there. If you go to the Ministry of Health and get the Universal Health Coverage Policy 2020-2030, which is still part of the larger 2014-2030 policy, I was deep in it. Yeah.
Okay. What are your hobbies? Your hobbies?
Well, I think just relaxing.
That is not a hobby.
Yeah, it's a hobby. Yeah, it's a hobby. from this very tough job.
That is not
Relaxing
a hobby.
is actually
No.
actually even just sometimes keeping quiet and meditating is
we have
it comes.
refused. That is not a hobby. Okay, I said hobby, so that is one. Give us another one.
Of course, I mean, when I'm free, I like traveling and seeing maybe the countryside, visit people, visiting people.
And what's your guilty pleasure? What's your guilty pleasure?
Well, I mean, sitting down with friends in a club.
Lakini sawa tu. You're not on the relaxing, you're just moving around relaxing, but it's okay, I see you.
It's not uji.
Okay. Well. A question for me now.
No, what's your guilty pleasure? Let's start from there.
Eating ice cream. I eat lots of ice cream. Not lots. Like I have a limit, but it's my guilty pleasure. Yeah.
What's the best book you read yourself?
It's called Ikigai.
I've heard of that. Ikigai. Yes,
it's a really beautiful book on purpose and all that.
Yeah, purpose. Yeah.
So thank you so much. We are done actually.
Oh, right.
Yes.
Great.
And I only have one last question to wrap this up. So my last question to you is, actually it's not a question, but it's more of your final message to practitioners navigating uncertainty and reform. Yeah.
Well, I think to all practitioners, mine is to give them hope that all is well, as long as we stay true to our oaths, first do no harm. Yeah.
Okay. Thank you so much, Dr. David Kariuki. And I was saying Kariuki David.
Both
which one do you prefer?
Still the same. Do you
prefer?
Kariuki is my surname.
Yes, but which one do you prefer comes the first? Dr. Kariuki David or Dr. David Kariuki?
Well, David Kariuki.
So it was odd when I was saying Dr.
No. Because people call me
Dr.
Kariuki, rarely does David come up. Yeah, it comes up in the writing.
Okay. So thank you so much for taking time to be with us and being in this session. You've really, opened our eyes in what KMPDC does, and you've given us clarity, and even your leadership and the way, you've given me, actually for me, myself, you've given me an understanding around, registration, licensure, understanding even a practitioner and facility-based and things they really need to know for safety, of course, patient safety, yes, and even standardization and what is required. So thank you so much for that.
Thank you. My pleasure too. And hoping that you'll get me back here again.
Yes.
Definitely
we
will.
Will. Yes. Yeah. This was to more of knowing who you are, and also to understand now what exactly KMPDC does and what it is, and even wearing the cap you've said for 3 years, and many transitions have happened within it, and you've brought that to light. So of course the next time we will have you now be focusing on that one deeper topic in length. Yes, and the stories you've been avoiding to tell us, they will come out. Yes, we will get you.
Yes, we'll be ready.
Yes. Thank you so much.
Right.
And to your listeners, thank you so much for joining us for this session. Just to point out that regulation is not our enemy. It is here to protect both sides. That is the doctors and, of course, the patients. We all matter when it comes to the healthcare system. To catch more of these kinds of episodes, follow us in all our social media platforms, and see you next.